On February 27th, the article Combined Occlusion and Home-Based Perceptual Learning Therapy in Children with Persistent Amblyopia, a longitudinal case series, was published in the Journal of Clinical Medicine. This is an article coordinated by my colleague Juan Portela, who is now going to explain this work to us. Good morning, Juan.
Good morning, Santiago.
You signed the paper together with two ophthalmologists from the Hospital of Merida, Dr. Maria Perez Benito, who is the clinical lead of the study, and Dr. Raquel Amigo. Also taking part are Teresa Calderon, an optometrist who regularly collaborates with Visionary and currently works at the Hospital of Mieres in Asturias, Professor Juan de la Cruz Cardona from the University of Granada, and myself, as I have not introduced myself. I am Santiago Martín, professor at the University of Oviedo and also a collaborator or promoter, together with you, of Visionary. I would like to begin by asking you what type of study we are talking about, because that is relevant.
Well, the study is a longitudinal case study in patients with patch-resistant amblyopia. What it does is analyze the evolution of visual acuity and binocular vision over the years in a public hospital. The sample is made up of complex patients with amblyopia who are resistant to patching.
Right, so we are in a public hospital and dealing with persistent amblyopia, what we call patch-resistant amblyopia. Can we go into a little more detail about what patch-resistant or persistent amblyopia means? Why do we call it that? I think the study consists of two phases. Can we explain a little more about which patients were included and what this involved?
These are patients in whom amblyopia is initially detected and the refractive error is corrected with glasses. At the follow-up visit, the patient still has amblyopia in one or both eyes, and patch treatment is started. These are patients who have been treated for many years with occlusion, and thanks to a recent study, we know that after a certain period of occlusion, there are no longer significant improvements in visual acuity. So, when the ophthalmologist sees that visual acuity is no longer improving with occlusion, we move on to the second phase, in which Visionary is prescribed for home use together with occlusion. In this study, all patients who had been treated with Visionary and occlusion were recruited by telephone. Of all those patients, 40 children finally attended a hospital review, where visual acuity and binocular vision were assessed again. Of those 40 patients, 28 had functional amblyopia, but 12, which is the interesting part of this study, had organic amblyopia secondary to a pathology. Of those 12 organic cases, 7 had congenital cataracts. Among the patients who did not have pathological amblyopia, 18 had anisometropia, 5 had strabismus, and in another 5, strabismus coexisted with anisometropia. The mean age was already relatively high, approximately 9 years, with a standard deviation of 3 years.
It is a truly diverse sample. As this is a longitudinal study, we first take hospital records from patients who have already been treated or are undergoing treatment. As explained, there are two phases. The previous occlusion phase, where I think the study mentioned an average of 48 months of treatment, plus or minus 21, with high variability. In other words, far above the 36 or 48 weeks that we consider the plateau of occlusion treatment, after which it no longer produces improvements.
The study that we considered in the article as the plateau point establishes 36 weeks for moderate amblyopia and 48 weeks for severe amblyopia. In other words, beyond that number of weeks, continuing occlusion no longer makes sense because there is no significant improvement in visual acuity.
That is interesting. The data are very varied because this is a clinical history with two very clearly defined phases, an occlusion phase and a phase of occlusion treatment plus visionary.
Exactly. The sample is indeed heterogeneous. It is not a standard study in which the inclusion criteria are very tightly defined. There are patients with strabismus, patients with anisometropia, and patients with a pathology. We are trying to reproduce the real world in a public hospital in Spain.
Very well, let us look at the effects that, according to the records, Phase 1, the occlusion phase, had produced. What was obtained? What improvements were seen in this group thanks only to occlusion?
Occlusion is a good treatment. The study shows how an improvement occurs in the overall sample. Initially, a mean decimal visual acuity of 0.36 improves to a mean visual acuity of 0.55. In non-pathological cases, that improvement is greater. They start from a mean visual acuity of 0.39, and at the end, after occlusion treatment, final visual acuity is 0.63. In pathological cases, of course, the improvement with occlusion is smaller. They go from a mean visual acuity of 0.30 to 0.39, less than 1 decimal line. In the cataract subgroup, there is a greater improvement. Subjects start from a mean decimal visual acuity of 0.45 and, at the end of treatment, achieve a visual acuity of 0.63. What happens with regard to binocularity? We do not have the baseline data because the ophthalmologists did not measure binocular vision at that initial point in the treatment. But after occlusion, 19 subjects were still suppressing and 21 had no stereopsis.
That is a very high percentage because the sample consisted of 40 patients. Then that phase of occlusion plus visual therapy with visionary begins 5 days a week, 30 minutes a day, and with no time limit. In principle, given the lack of an alternative, the endpoint of Phase 2 was success.
The doctor considered that a patient could not be discharged until they had a visual acuity of 1.0. Until they had a visual acuity of 1.0, treatment with occlusion plus visionary continued.
Very well. And what improvements were recorded in the patients in this second phase?
Overall, almost 3 decimal lines. In other words, patients go from an initial visual acuity of 0.55 to a mean visual acuity of 0.74. That is a major improvement. In non-pathological cases, they go from a mean of 0.63 to 0.81 decimal. In pathological cases, there is almost a 2-line improvement from a visual acuity of 0.39 to 0.60. That is a major change. And in cataracts, incredibly, this is the group that achieves the best final visual acuity. From an initial mean of 0.63, they go to a mean visual acuity of 0.85. These are truly surprising results.
Did binocularity also improve?
Of the 19 patients who were suppressing at the start of treatment, suppression was lifted in 9. However, the treatment did not work in terms of binocular vision. In pathological patients, there were no changes in binocular vision, either in suppression or in stereopsis. Visual acuity also recovered in 6 of the patients who had stereopsis at the start of treatment, and overall, there is a significant improvement in stereopsis measured in seconds of arc with the TNO. We go from a mean of 1,928 seconds of arc to 748 in non-pathological cases, from 949 to 685. But as I say, in pathological cases, there is no improvement in stereopsis.
Of course, we have not been successful in that subgroup.
I think that ultimately, the pathology produces a significant reduction in binocular neurons, and the treatment we are proposing is not yet intense or powerful enough to recover stereopsis in these patients.
we also have patients with strabismus. I think there were 11 patients, 6 esotropias, 3 exotropias, and 2 hypertropias. 5 of those patients underwent surgery. Did the deviation improve, and did they acquire binocularity?
That is very interesting, because the treatment proposed by the ophthalmologist also involves prismatic correction, surgery to correct the deviation, and therapy with visionary. Of the subjects with esotropia, 5 underwent surgery, and of those 5, all acquired fusion. 3 even acquired stereopsis, measurable with the TNO. These are spectacular results in terms of binocular vision in patients with strabismus and a surgical indication.
In the second phase, by using visionary in addition to the patch, we have the advantage that visionary records adherence to therapy. We can therefore calculate treatment intensity. In the study, we divided the sample into patients who had worked with visionary for less than 10 hours, 15 of the 40 patients, and patients who had worked for more than 10 hours with visionary, 25 of the 40 patients. What can we say about the effect of treatment intensity?
It is a very interesting result, and moreover, it is the first time adherence has been analyzed in this way. I think it is a starting point for future work. We considered success to have occurred when final visual acuity had improved by 2 lines or more, or when visual acuity was equal to or greater than 0.8. Among good adherers, 72% of the sample, 18 out of 25, were successful. When exposure to the game was less than 10 hours, success occurred in only 40%, 6 out of 15. Something similar also happens with stereopsis. We considered there to be an improvement when the level of stereopsis improved by 2 levels, or in cases where there was no stereopsis at the start of treatment, and the patient acquired some stereopsis, even if it was coarse. Here too, success depends heavily on adherence. We go from a success rate of 40%, 10 subjects out of 25, who managed to improve their stereopsis, to 20%, 3 out of 15, when adherence is poor.
Of course, some patients worked far more than 10 hours because, as we said, Dr. Maria Perez Benito maintained treatment until a decimal visual acuity of 1 was achieved, or until the patient abandoned it. In that sense, we also have a novel record. What happens when visual therapy, in this case computer-based and with visionary, is prolonged for a long time? We found patients who had been in treatment for up to 130 weeks. What could be inferred from this very long record of activity over time?
As these are very prolonged treatments, we have realized that there is also a plateau effect. In other words, there is a 90% probability of no improvement at 110 weeks. There comes a point at which, no matter how much you work with visionary, there is no longer a significant improvement in visual acuity. There is also something very interesting. Adherence to the game is very good. Although patients spend a long time playing, the probability of abandoning treatment does not exceed 70%, even in patients who have worked for more than 130 weeks.
They really are highly motivated patients. I understand that the patients who spent so long working were cases of profound organic amblyopia, and that the patient truly values the possibility of recovering vision. To finish, an analysis was carried out to calculate the predictors of treatment success according to the sample. What results did we obtain in that analysis?
One thing we wanted to know was which factors influence prognosis. Which factors make the probability of success higher? So in this multivariate analysis, we included different factors such as initial visual acuity, perception of stereopsis, the presence or absence of pathology, the presence or absence of strabismus, and also adherence. In the end, the strongest factor, the one that most influenced prognosis, was adherence. People with good adherence were 5 times more likely to improve their visual acuity and 7 times more likely to improve stereopsis. The adherence factor is the main factor in determining success or failure in this population.
That is very interesting. It is a very motivating result with immediate clinical usefulness. This is a complex study in a public hospital, a longitudinal study. I understand that we have also faced problems, shortcomings, and things we would have liked to do better. The limitations of the study.
For me, the main limitation is the absence of a control group. Then, although we recorded adherence because visionary makes it possible to know each patient's adherence, for example, we did not control adherence to glasses or adherence to the patch. And there is always a certain placebo effect that could not be controlled. There are limitations, but we know what they are. In future studies, we will be able to address these limitations with better designed studies.
The truth is that it is very interesting. Thank you, Juan, for this explanation of the study. I am sure we will try to carry out even better studies, but this one is not bad at all.